Hi, I'm Dr. Suzette Glassner, clinical psychologist and associate professor of psychiatry at UCLA. I am so pleased to have today's guest, Gary Mendell, here with me. Gary is founder and CEO of Shatterproof, an organization that is dedicated to breaking through the stigma associated with substance use disorder, or as many of us know it to be, addiction.
Yeah, and Suzette, thank you for having me, and thank you for all you're doing to educate so many people about this medical condition. Thank you.
Likewise, I'm really looking forward to talking to you about Shatterproof today. I know that the inspiration for starting Shatterproof came from the tragic loss of your son many years ago. And I would love to hear, just to start us out, a little bit about Brian and Brian's story and how it led you to where you are today with Shatterproof now 12 years later.
Sure. Thank you for asking. I was raising my family in a small town in Connecticut, and my older son, Brian, like many, tried beer to start just before high school. And that led to harder drugs, and he developed a substance use disorder. He was diagnosed as a junior in high school. Over the next 8 years, he went to 8 different treatment programs, always trying his hardest. Sometimes it was easier, sometimes it was harder. When he would usually get out of the treatment program, he would relapse, and we would have to get him to another treatment program. But he was always trying his hardest. I can't tell you how many times he would just look at me with that big smile of his and say, "Dad, don't worry, I'm going to get this." But addiction always doesn't work that way. And on October 20th, 2011, I was woken up in the middle of the night and told that my son had just died. He was 25 years old, and he hadn't used a substance in 13 months. And it just obviously doesn't get any worse than that. And equally tragic, it wasn't just substance use disorder or addiction that took my son's life. It was the feeling of shame that he had every morning when he opened his eyes, that the history on his computer shows. He woke up that morning, researched suicide notes, wrote a note of his own, and took his own life alone. So in the weeks that followed, struggling to get up to live, I began to focus on 2 questions, all based on the Serenity Prayer. The first was, what could I have done differently as a father? And based on the first sentence of the Serenity Prayer, whatever that was, I had to accept it. And then the second sentence, the courage to be able to change what you can. And with Brian in my heart, who always wanted to help others, what could be done to spare other families of the tragedy that my family had suffered? So I took what I thought would be 3 months away from my business and traveled the country, meeting with experts, looking for answers to those 2 questions. After 3 months, Suzette, I had learned so much. And I'm kind of old school. I print everything out, put it on 3-ring binders with little note tags. But I said, let's summarize it on a sheet of paper. One side, I wrote number 1, big. I had no idea of the magnitude of how many people this medical condition touched. 3rd largest cause of death in this country behind heart and cancer. 1/4 of American families, someone in their family is addicted, mother, father, son, or daughter. That was big. And then I wrote number 2, children. I learned in that 3 months that literally 8 out of 10, not 100%, but 8 out of 10 of those with a substance use disorder had developed this medical condition before their 18th birthday. And we as a society were just letting it happen to our children, our teenagers, when their brains were not fully developed to be able to protect themselves. And then I wrote, Suzette, number 3, tragic. And what I meant by that was not that my son had died. What I meant by that was I had learned that our federal government in the couple decades prior had funded about $20 billion worth of research to researchers all across the country. And those researchers had successfully used that funding and created wonderful bodies of knowledge that had proven without any doubt through randomly controlled trials, if our healthcare system and our families and our communities did certain things, 20 to 40% less of our loved ones would use substances and develop this condition. And a second body of knowledge that had proven, again, without any doubt, if our healthcare system followed certain protocols for those who had developed this condition, they would recover at success rates on par with those being treated for any other chronic illness like heart disease or diabetes. But I had written the word tragic because I learned it was all buried in medical journals and hardly any of it was being implemented. As a father, it destroyed me. All this information that hardly anyone was using, families or our healthcare system or our communities, But then I saw an opportunity coming from a background in business. This could be changed. And I asked myself, why is all this information buried in medical journals? And I wrote number 4, no national, well-funded nonprofit like American Heart, American Cancer, Susan Komen, Autism Speaks. For every major disease, there was one well-funded national organization leading the fight to protect our families from their respective disease. And no organization existed on any scale and scope comparable. And I asked myself, how can that be? And I wrote number 5, stigma. I could have walked into any restaurant in America in 2012 and said, I have a charity for addiction. Would you donate $1? People would have looked at me like I had 6 heads. Are you kidding me? Just throw them in jail. Why would I donate $1 to a charity? But I could see this could change. And from this, I decided to leave my business, dedicate my life to building that type of organization for this disease with 3 guiding principles. Number 1, everything that we do would be based on science. Let's lift the research, the proven research out of the medical journals and get it implemented. Number 2, everything that we do would not only be helping people today, we would purposely choose impact programs that in addition to helping people today, we would catalyze partnerships to change the system, changing the system for our children, grandchildren, great-grandchildren, future generations. By partnering with states, community-based organizations, health insurers, other nonprofits, for-profit businesses, work together to do that. And number 3, run this organization efficiently like a well-run for-profit business with business metrics. That was the formation of Shatterproof, a little over 10 years ago.
The way that you're hitting on so many things that I think a lot of us in the research community are somewhat painfully aware of is that I'm one of those recipients of those grant awards for developing and studying efficacious treatments for substance use disorders. And it has always troubled me that I felt like as a scientist, I was circulating information about substance use disorders and their treatment and ways of helping people move forward, ways of preventing adverse and tragic outcomes, circulating those findings amongst myself and other scientists. And that's a big part of the reason that I've started this podcast, why I wrote my book, to try and really spread knowledge about what is sadly resting in medical journals and is a little bit lost on the public and public awareness. So it's incredible that you were able, as a non-scientist, as a non-expert in this field, to sort of uncover that through your own research over the course of that year or so after you lost Brian. I think one thing that jumped out at me when I hear you speak, because the first time I heard you speak, it was as a researcher in the community of individuals who were funded by the NIH HEAL initiative, or helping to end addiction long term. I saw you speak at our first annual meeting, like must have been 5 years ago. And both then and now, even though I know a long time has passed since you lost Brian, I find that you speak with so much authenticity and so much courage. And one thing I wonder about you personally is, what is it about you that enables you to take a tragedy like this and transform it into a way of finding life meaning and purpose and impacting other people? Because a lot of people, I don't know, might not have some of what you have internally, or maybe in terms of support or a mindset, but I'm very curious about what empowers you to do that in the face of so much pain that you must have been facing after you lost Brian.
A few different perspectives. One is I have a background as an entrepreneur building businesses. So that gave me a perspective of how I can partner with others that had so much expertise in different areas, like yourself, number 1. Number 2, sure, this started with Brian in my heart. And looking at that serenity prayer, that second sentence, first 2 sentences, the serenity to accept what I couldn't change, but being able to focus on helping others. But I can honestly say, Suzette, that it's so much more beyond that now. I've had the opportunity to meet so many wonderful people all across our country, including yourself and so many others that are so passionate about helping others that it inspires me every day. And meeting young people or any age of people in recovery, working through it, and meeting parents who've lost a child like I did who didn't have to. This is not 100%, but largely preventable. And all this wonderful research, let's get it implemented, block and tackle. Just get it out there and get it used. It's inspiring to be able to do so. And it's further inspiring by meeting so many wonderful people that just warm my heart every day.
That's amazing. I mean, really, truly, we're lucky in the field of addiction science and treatment to have somebody like you doing sort of the extension of our work. Sure, we're developing the treatments, we're studying them, we're testing the outcomes, but you are actually out there talking to people who are impacted by this illness and who have lost loved ones in the process, and also people who have hope for recovery. And I think that's one of my important messages, is that there is hope for recovery. We know that there is, but it takes the important work of people like you to spread that message and also to help bring people into the how. So I think that's sort of the next question I have for you. There are so many aspects when you describe Brian's story. There are so many directions that you could have gone with this. You could have gone into improving the addiction treatment system, which actually I think you do touch on all of these, but in terms of
Yeah.
focus of your organization, you could have gone into mental health advocacy. You could have gone into more focused work on suicidality in youth, or you could have even gone in the direction of the specific substances that your son was using that led him down this path that he wasn't able to return from. So it could have been opioids, but you chose to focus on stigma. And I'm really curious to learn more from you around how you feel that the experience of stigma, I think you touched on it already, but the experience of stigma tied to the outcome of Brian's addiction and multiple treatments that he wasn't able to come back from. Like, what did stigma specifically have to do with it?
I have to be honest and say I really didn't understand it when Brian was alive. And I mentioned a few minutes ago, the research I found was based on prevention and treatment. And we started out with a focus on treatment. But as I learned more, it became very clear to me that the stigma, the discrimination against those with this disease was one of the main drivers of all of it. And I looked at the opioid epidemic, for example, and we identified 9 drivers, and 7 of those 9 were either partially or fully driven by stigma. And then I started to see, as I looked at data, 75% of the public doesn't think this is a disease. 75%. 60% of the public is unwilling to be a friend, a coworker, a neighbor of someone with this disease. Over a third of those feel ashamed of themselves. More than half of doctors don't think this is a disease. 45% of doctors don't think medications are effective when they are. And I started to see that and think about it and understand it and think about the impact of it and think about what caused Brian to take his own life. I realized, in looking at those drivers, it became very clear that this was the foundational element that needed to be changed and could be changed. One thing that I always think about, Suzette, is the last time Brian came home to visit. It turned out to be 4 months before he passed away. And that last weekend, we had a great weekend. I beat him with a 30-foot putt that morning and had a family barbecue in the afternoon. But that night, we're sitting on the back porch, just the two of us. And he looked at me and he said, "Dad, I wish that someday people would realize I'm not a bad person. I'm a good person with a bad disease. And I am trying my absolute hardest. I promise. And I wish people would understand that." And I started to get a little of it that day, but it wasn't really, I was deeper into Shatterproof that it really hit home for me of the foundation of it and how important it was. In answer to that first question I was searching for, what could I have done differently as a father? I had a great relationship with Brian. Everyone said that Brian said, his dad was his best friend. But whenever he would relapse, I would say, "Brian, it's okay. Let's get you back into treatment. Maybe you learned something from the last treatment program that you can apply. Maybe you could try a little harder." And it was said softly with love and all that stuff. But I didn't. And this kills me. I never said, "Brian, this must be hard for you." If he had cancer and all his friends were going to college and getting jobs and he was at home getting chemotherapy, I would have said, "This has to be so hard for you." I didn't say it with this because I thought he could try harder. I thought it was within his control. And for some people it is. And for some people, it's harder to be in their control. At his 6th treatment program, he was giving the medication for those addicted to opioids that works. In his 7th treatment program, they took it away because they didn't believe it worked. It was good people. I'm not saying there were bad people at this treatment program, but they did not believe it worked. That is the stigma against medications. It's there to be done. It's just there to be done.
Yeah, a lot of what you're describing is quite relatable. Part of my research at UCLA has been focused specifically on stigma related to taking medications. And we've done a lot of interviews with individuals who are now taking Suboxone, which is a medication for treatment of opioid use disorder. And there's a lot, as you know, of misinformation and misunderstanding about what Suboxone actually does in the brain. And, that the most common misconception being that it's replacing one drug with another and that people are taking it to get high, when if they actually understood what Suboxone does and the way in which it actually stabilizes the brain and makes somebody feel normal, rather
Right.
than high when it's working properly, then they wouldn't hold those beliefs. I wanted to actually read to you a couple of the quotes from some of our research participants about Suboxone and their experience taking Suboxone and the stigma around it, just to get a little bit of your take and your thoughts and whether this sounds
Sure.
familiar to you. Okay, so in one of our studies, we asked, what do you think other people think about Suboxone? And this one person we spoke to said, pretty much it's just for addicts, and maybe they're too mentally weak to do it on their own. Just mainly it's a negative stigma. And the second person we spoke to, who didn't want to tell his sponsor from the 12-step program that he was working about taking Suboxone, we asked him, why haven't you told your sponsor you're on Suboxone? And I want to be clear that this is a story about this person's sponsor. You could substitute anyone there. You
Correct.
could say your mom or your friend or your
Right.
colleague, right? But this was just an example of what this individual shared with us, that he was scared to tell his sponsor. And he said, he doesn't want me to take that stuff at all. I mean, it's pharmaceutical heroin. That's all it is. And I just wanted to see kind of what thoughts come to mind for you when you hear this, and a little bit about what you and your team at Shatterproof have learned about the impact of stigmatized views around taking medication. What's the impact of that you can see on people accessing treatment? Yeah, anything that you've looked at, because I know that you all have deeply studied stigma and have developed a measure of stigma. So I just wanted to get your take on that.
Absolutely. And just to back up on how we've studied it, we worked with one of the largest consulting companies, strategic consulting companies in the world. They worked pro bono for a year and a half for us. And we studied 11 social movements on how to change the public's knowledge, attitudes, and behaviors, and developed a plan to do so for addiction. So we've studied this inside and out. An answer specifically related to Suboxone, those two stories I hear all the time. Suboxone is a partial opioid, but it absolutely works. People don't get high. It significantly works. That was the medication I was referring to related to my son, and it was the best he ever did. And that's why he went 13 months substance free, and he didn't relapse. But they took him off it because they didn't believe in it. He fought relapsing, but I think he was really struggling with it. He told my niece, which I didn't know about, but she talked about at his funeral. She said, I spoke to Brian a month ago, and he said, Jamie, it's like I have this itch in the middle of my head and I can't scratch it. And when I had the Suboxone, the itch went away. It works. And people talk about sometimes, all right, I'll be on Suboxone for 30 days or 60 days. You could be on it your whole life. It's okay. And there's now Sublocade, which is a shot that goes 30 days, which is even better because it keeps it even in your bloodstream for 30 days consistently, all the time, 24 hours a day. It's consistently in your bloodstream and even flow. It works. And what I heard you say is I hear all the time. I can tell you, though, the good news is we've developed a program to educate the public about this. We're operating that program in 5 states right now, representing now 27% of the United States population, because it includes California, which is 13% right there. And in 1 year, we have reduced the stigma against medications by over 10%. In just 1 year. And we just got renewed for another 2 years in California and many of the other states. So we're just going to keep reducing that stigma so people are not ashamed to take it. Doctors are not ashamed to prescribe it, et cetera, et cetera.
I'm curious, who did you survey around their changing views around medication when you say the reduction by 10%, which is incredible? Is that people who are taking it? Is it healthcare providers? Is it all of them?
We surveyed the general public, and I can't remember exactly the sample size. It was several thousand people in the general public. We do it before and we do it after.
That's incredibly powerful, because I'll say that was just 2 examples from 2 research participants. But in my clinical practice, practice, I've seen this a lot as well, that when you have the opportunity to educate a family, a loved one about what a medication like Suboxone really does, and I've seen that medication transform lives, and I've seen people transition from wanting to be on it temporarily to actually saying to themselves, I actually never want to stop taking this. Not everyone
Right.
feels that way, and not everyone should feel that way per se, but once they realize that they actually get their life back when their brain is stabilized, because the brain is ultimately, it's altered by chronic substance use. It's not the same brain as it was when somebody started, particularly with opioids, that some brains need a little dose of opioid substitution in order to function normally, to have a job, to have a wife, to have a life.
Absolutely. If you have diabetes, you'll take insulin your whole life. So what?
Exactly.
That's great.
Exactly.
If you're addicted to opioids, take Suboxone or Sublocade your whole life. It's okay. That's great. And you won't need to use substances again. The itch will go away. The other thing I just wanted to mention, that was the public campaign that I mentioned that we're still operating in several states. And we just added another state a few months ago. But we also just started an educational program for healthcare professionals, because 45% of healthcare professionals don't think the medications are effective. And we're now implementing that. It's 4.5 hours of content. We just finished it. We worked on it a year and a half ago with Yale as our partner. The content launched 4 or 5 weeks ago, and now we're out there educating healthcare professionals. So that's a second audience to change the way that they think about the medications.
That is going to be such impactful work. I'm so happy to hear that you're doing that. It's going to be a game changer. It sounds like it already is. There are different forms of stigma that we understand. Structural stigma amongst healthcare professionals. One form of stigma that I think is almost precisely what you described as Brian experiencing.
Self.
Yeah, or internalized stigma. So that people being treated in a certain way because of their addiction, or even because of their mental health, or, other stigmatized conditions that they have, they begin to internalize what other people are projecting that they view, that their addiction is a choice, that they're a bad person, that it's a moral weakness or failing. They start to internalize a lot of that. And one of my questions for you is, like, whose problem do you think that is to solve? Do we solve that by talking to healthcare professionals? Do we solve that by helping the person with the substance use disorder?
Yeah, so let's look at the stigmas. There's public stigma, what the public thinks. As I mentioned earlier, 60% of the public is unwilling to be a friend, a coworker, or neighbor of someone with a substance use disorder. 40% of the public is unwilling to be a friend, coworker, or neighbor of someone with a substance use disorder who's in recovery and hasn't used a substance for a year or longer. Think about that one. So that's the public. Then you have healthcare professionals, which I mentioned a few minutes ago, but that's in that area called structural stigma. Can you rent an apartment? Almost 40% of hiring managers in the employer sector will not hire someone who's known to have a substance use disorder. That's structural stigma. Policies, structural stigma. And then there's self-stigma, which we'll touch upon in a second. And I always like to pull out as a fourth, so it gets the real attention, the stigma against medications versus bearing it within structural. So to call it those four. So how do we reduce self-stigma? The main ingredient is the other three. If you can't rent an apartment because you have a substance use disorder, you're getting messaged, you're no good. If people are uncomfortable being around you if you have a substance use disorder, whether you're actively using and need help or you're in recovery doing well, the message is coming to you, even though you haven't read the statistics, but you're feeling, I can't tell anybody or no one's going to want to be around me. So that's the public. And then there's structural, and it's all coming to you. I often wonder, and my son never told me this, but he was living in LA at the time. He died. Did he happen to look at his Facebook feed one night or one evening and say, wow, they're doing a big walkathon to raise money for cancer research? And, kind of went in his mind, out of his mind. He just saw it, flipped through. And I'm just guessing. And then maybe a month or two later, he turned on the news at 10 o'clock. Wow, they're doing a bike-a-thon to raise money for autism. And did he think subconsciously, they don't do that for me. I'm not worth it. And back to where I was at fault. I never said this must be tough on you. I said, can you try a little harder, Bri? My mistake. I have to live with it. And I have to have the serenity to accept it and go on and use that information to help others. But in answer to your question, if we reduce public stigma, structural stigma, the stigma against medications, it will filter down and reduce self-stigma.
Yes.
And at the same time, working with therapists, psychologists, psychiatrists, and doctors, nurses, that will help also reduce, because they can work with patients and get them to understand and empathize with them and teach parents and families how to empathize and admire those who are fighting through a difficult medical condition that they never asked for. I've never met anyone in 12 years doing this, Suzette, that said, I reached my hand to the sky one day and said, God, please addict me. Everyone I've met, which is obvious, didn't do anything different than anybody else. They tried beer in the backwoods or behind a building when they were 13 or 14 years old. And 2 out of 10 said, yuck, that tastes horrible. I'll never do it again. 7 out of 10 said, yeah, that's pretty good. I'll try it at a party sometime in a month or so. And 1 out of 10, it just connected with them. Maybe it was genetic. Maybe they had some anxiety or depression that it helped soothe. But for whatever reason, it started to connect with them and they started to use it privately and developed a substance use disorder. No fault of their own. And as you mentioned earlier, it changed their brain chemistry. But the great news is we can help so many of those. We just reduce those stigmas. That's the great news here. By the way, I forgot to mention on those 5 things that I wrote on a sheet of paper, I crossed out the word tragic and put the word, let's get this done.
Well, you certainly have made a ton of headway towards getting that done. It's going to be ongoing, but the identification of those different sources of stigma, and I really like the way that you frame it, that like, where does the self or the internalized stigma come from? It comes from these external sources that if you can correct and educate and help them understand addiction as the illness that it is, rather than as a choice, that's really the first step towards changing the individual who's affected. Either that or you help them to insulate themselves from that. And that's something that we also try to do because the stigma's out there. So you have to find a way around it mentally and develop some resilience. We actually, from that same research study, we developed an app that is in a clinical trial now in which we deliver messages about stigma specifically when people are starting to take Suboxone, where we tell them somebody who's in recovery who's taking Suboxone said, and we share with them some of those anecdotes like, you have to take care of yourself. You have to do what you know in your heart is right for yourself and take the medication if it's helping you get your life back. There's no shame in that. But that's something that needs more broad dissemination than just a handful of people in a clinical trial.
Absolutely. And I would add 2 things. We stopped using the word disease. We started using the words treatable disease.
Yep.
I can't blame anyone that may not want someone with this disease as their neighbor, friend, or coworker if it's untreatable and you could cause harm. But this is like a medical condition like any other that's got medications to treat it and therapies to treat it, where it is a treatable disease. And treated with the science, most people recover and live full and productive lives. The other thing is, you mentioned earlier, a few minutes ago, the word hope. I love the word hope because it's an emotional word, but I don't like it because hope to me, maybe I'm just a numbers guy, is like 1 in 100. You get treated with science, proven protocols based on randomly controlled trials of what has worked, it's expected you'll recover and live a full and fulfilling life.
Yeah, the data actually really support that because there are a lot of people living in recovery. I think we hear a lot about the sad stories, and especially on the media side of things, we hear about the most devastating outcomes, but we don't hear enough about the stories of success that come through people who have leveraged these treatments to get well.
Right.
So, yeah, I couldn't agree with you more.
We treat this like a medical condition like others. Everything changes. People are not ashamed of themselves. People get treated like they have a medical condition, just like they have diabetes or heart disease.
Exactly.
They get treated in the healthcare profession with medications that have proven to work, with therapies that have been proven to work. And we start using some of the prevention science so less people develop this condition. Everything changes. And what a better world for our children, our grandchildren, our great-grandchildren.
Absolutely. One thing I wondered listening to you talk about Brian, and he went through 8 treatment episodes, I believe.
Right.
And most people would look at Brian's situation and think, wow, he was kind of maybe the greatest chances of success because you were able to get him access to treatment. He would have the ability to go to treatment 8 times. He has very accomplished, educated parents who are tuned in and trying to figure out what's going to work for him. And I know you mentioned that he was taken off of an evidence-based treatment, and maybe that's the answer to this question. But I guess more broadly speaking, I was wondering, how did treatment end up failing him? Because 8 times, and like, that's a lot of treatment. Just wondering what you feel. And that's probably part of your reflection on what, went wrong or what more could have been done.
I think shame and stigma was a huge part of it. No matter what income level you're growing up in, if you're feeling ashamed of yourself, it's huge barrier to doing well. So I think that was a huge part of it. And I think that our society and us as a family not understanding that was the main driver leading to his death. That's what I believe. And I have to live with that. I don't want to knock the treatment industry, because I met in those 8 programs and since forming Shatterproof, so many wonderful people running treatment programs and working in treatment programs. But it's no question, actions of what happens in treatment programs is behind, many, many years behind what the science shows. And that is the other reason. Again, you can go to as many best treatment programs in the country if they're not doing the right things. And again, I had all the resources that anyone could have. But one treatment program, I called Brian one time. I said, "How was your day?" And he said, "Fine." I said, "What are you doing now?" He said, "Dad, I'm scrubbing toilets. They're trying to build my character." With a toothbrush, he's scrubbing toilets, he said. Another treatment program, I said, "Are you treating him he's got anxiety. Do you treat him for his anxiety?" "Oh, no, 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 no. We don't treat anxiety. He's got to stop using drugs, and then he can go to therapy and worry about his anxiety." After I read the research after he passed away, one of the key ingredients of treating someone based on science-based protocols is to diagnose someone for all 3 things: substance use disorder, mental health issues, and physical issues, all 3.
That's right.
And develop treatment for all 3 at the same time.
That's exactly right.
Another, reimbursing healthcare professionals for the collaborative care model, where you're working together with a psychiatrist or a psychologist and a primary care doctor and a care coordinator. It doesn't cost any more to pay for treatment that way. Instead of paying for it individually, you pay for a team. I didn't know anything about the collaborative care model, but intuitively I knew a little bit. I used to organize calls on Tuesday nights with his therapist, the person running his sober home, and his main person in the treatment program he was in. So all 3 would talk to each other.
That's what's supposed to happen.
But it wasn't happening. And again, I'm not saying these were bad people. It wasn't taught in medical schools. It wasn't taught. These weren't doctors trained in medical school on a medical condition. This was outside our healthcare system. Mm-hmm. Everyone doing what they thought.
Right. Yeah, there's a lot of research supporting that sort of importance of integrated care for mental health and substance use disorders. We've been trying to put it into practice for a long time. And those who do it well really get it right and get great outcomes. But we definitely need to see more of that. That actually leads me to another question I had for you about Brian's mental health.
Sure.
Like, where do you see that in the overall picture? Was he not getting sufficient treatment for his mental health? And like, what did his mental health look like?
I don't know exactly. I know he had some anxiety growing up. Sometimes his palms were a little sweaty, kind of like, I played high school football and I had butterflies in my stomach. I think he had a little of that growing up. I think that the stigma became a mental health issue where he became really ashamed of himself. And I also found out after he died that in his therapy sessions at the treatment program he was in, which was an outpatient treatment program, and he was living in a sober home, he had different therapists there. To 3 different therapists over the 6 months prior to him taking his life, he mentioned suicidal thoughts. I found out later when I got all the notes, not one of those therapists had told the other 2. They hadn't connected the dots. They never told his mother and I. And in fact, the day before he died, they released him saying, "You're okay to leave." They called his girlfriend, who is also a patient, and said, "Stay away from Brian. He could be dangerous, like from anxiety. I mean, not physically dangerous, but not healthy to be around him." And the next morning he woke up, researched suicide notes, and took his own life. And it was later determined that the treatment program graduated him, if you will, because they didn't want to take the risk of having someone commit suicide while they're a patient of their program.
That's so heartbreaking.
It is just so heartbreaking. And the way I look at it now, the only way that I can survive is, I think, worst case, and I think I know worst case, from his loss, we are helping so many people. Worst case. Best case, he's watching and loving it. And can I prove it? No. Do I think he's watching us right now? Yes, but I can't prove it. But I know I can prove we're helping people. I have the stories of lives we've saved. I have the hugs from parents who've told me we've saved their son or daughter. And it's not just in reducing stigma. We've also really focused on treatment. We developed and published and have gained broad industry acceptance on our nation's first national standard of care for the treatment of addiction, We then developed a quality measurement system to gather data to show which treatment programs are following science-based practices and which ones aren't. And now people looking for treatment can go to our website for free. It's shatterproof.org. You go to our website for free, hit the button that says find treatment. And if you're looking for treatment in one of the states we're active, which is 14 states, but it's large states, so it's almost half the United States population, you can easily determine a treatment program that's following science-based practices versus ones that aren't. And you can take a 10-question assessment that was based on the science of the American Society of Addiction Medicine. They built it with us and instantly get a recommendation. Do you need outpatient or you need residential? Do you need medications for opioid use disorder? Do you need medications for alcohol use disorder? Do you need mental health services? And then it narrows the list of the treatment programs to exactly what you need.
It's a resource we have never had in our field, honestly.
Correct.
I mean, is this Treatment Atlas?
It's Treatment Atlas.
Yeah.
And the other beauty of it, remember I told you our original guiding principles is not only helping people today, but changing the system. What we're doing is we're licensing the data to health insurers, and they're using that data on who's following evidence-based practices and which ones aren't to build better networks. So treatment providers that are in their networks that are not following the evidence-based practices, they have to start or they're no longer in their network and don't get reimbursed. And they can see treatment programs that are not in their network currently that are following science-based practices to reach out to them to get them into their network. That's improving the quality of care for our grandchildren, great-grandchildren for the next hundreds of years.
Absolutely. And there's so much confusion when I talk to people who just don't know, who just aren't addiction experts or substance use disorder experts about how it's treated. They cannot understand the distinctions between what's outpatient, what's residential. How do you know what you need? I mean, what you're doing with Atlas.
I had no idea. And ripping people when they need it, great. If they need residential, they should go to residential. And a lot of people do. But if they don't, and they can be treated with a medication and a therapy or 2 or 3 sessions a week while they keep their job or they stay in school and they keep their friends, they'll do much better.
Absolutely. And the research supports that.
Absolutely.
Low intensity, longer term treatment is just as good, if not better, than briefer, more intensive inpatient stays. So
unless you need it.
Right. And some people do.
And I had no idea. But we built it on the science of the American Society of Addiction Medicine, which is the gold standard, 3 decades of research of what level of care you need. And that just gets them in the right spot, outpatient or residential, with a place that has the services they need, medications or behavioral therapies, whatever they need, it's there. And then they can get a more sophisticated titration of, okay, I need outpatient. I'm in an outpatient. Do I need level 1, 2, 3, 4, 5? And it may change as the person progresses.
And most people don't know that there is actually a science behind that the American Society of Addiction Medicine has done this great work to give us guidelines for determining what level of care somebody needs. So it's actually a science. It's not guesswork.
Absolutely. And I had no idea.
Yeah.
And I remember being at a treatment program, one of the best in the country, supposedly. And I'm talking to the counselor or the therapist. And she looks down in my briefcase and she sees a catalog for the local junior college. And she said, "Why do you have that in your briefcase?" And I said, "Because I was just looking through it last night. And I know Brian is considering going there. And I just want to be able to answer questions he may have about what courses to take." I said, "Gary, you're reading and learning too much. Stop reading about addiction. Stop looking about colleges. Let Brian figure this out on his own." Like, I should have read and learned more. I would have learned about all the research that was buried in medical journals. I would have learned that it wasn't appropriate for him to be going to 8 different residential treatment programs. He felt stigmatized. He felt like he didn't need it. And when he was on the medication, it was the Suboxone. It was the best he'd ever done. Actually, he didn't go to 8 residential. He went to 6 and then 2 outpatient. But one of the outpatient ripped him off the Suboxone. Tragic, but solvable.
Yeah, that's in a nutshell.
Serenity to accept what we can change and change what we can.
You did the best you could with what you knew at the time. You know so much more now. Actually, this kind of links to something else I wanted to spend a moment with you on, which is, interestingly, when I was writing my soon-to-be released new book, Addiction: What Everyone Needs to Know, I mentioned it to a colleague at UCLA. And the first thing she said to me, a psychiatrist who's a very, very talented addiction specialist at UCLA, and the first thing she said to me was, "I hope that you have a part in that book that is just for parents that tells them that this is not their fault. Do you have a part in there that says that?" And I said, I think I do cover that, but I just found that was so interesting that was the first thing that jumped out at her. If I'm writing a book to the general public about what addiction is, the most important thing in her mind was to make sure that it was clear to parents that this wasn't their fault. And I guess, just from talking to you today, Gary, I hear how you grappled with what could I have done differently, what I have to accept, what I have to live with that I didn't say that I should have said. I guess I wanted to just get a better understanding from you of have you worked your way through that? It sounds like you did, which would be natural, experience some of that self-blame or guilt yourself for Brian's maybe development of a substance use disorder, or maybe for the way that it turned out for him. But just would like to know just what your journey with that has been and what you would say to other parents about that.
I guess a few things, again, from a few perspectives. I only have one choice, which is the serenity prayer. Have the serenity to accept what I just can't change. Yes, I tried my absolute hardest, but I now know I made many mistakes, and I have to have the serenity to accept it. And that's the only answer to that. There's so much more. We've talked a lot about it with treatment that could have been done differently if I knew more. Also, prevention. One of the first things I learned in that 3 months that I was traveling, I started reading this research about the risk and protective factors. Those who use substances at the first time at age 21, 4% likely to develop a substance use disorder. Start between 19 and 21, 7 or 8% likely to develop a substance use disorder. 15 to 17, 13%. Below 15, 23%. If I had known that as a parent, and I could have delayed Brian having that first beer from age 13 or 14 to age 17 or 18, the chances of him developing a substance disorder would have been cut in half. But I didn't know it. Can I blame myself? I don't even go there. I have to have the serenity to accept what I can change, and I'm less about looking backward and more about looking forward. And the last picture I have of Brian alive was helping someone on the street. And that is by my bed. It's in my office. It's everywhere. And that's what I have to live by. And again, I want to emphasize it's far more than Brian right now. I meet so many wonderful people who've lost family members, people who have family members in recovery, people like yourself in the field, policymakers, research, so many wonderful people who inspire me every day.
Thank you so much for sharing that. It's so deeply personal. And it is something that I think so many parents struggle with. Brian sounds like he was an amazing person.
Thank you.
One thing I'm wondering, of all the things, you're doing so much at Shatterproof, of all the things that you're doing to change people's lives with stigma and with treatment and with Atlas and giving people a voice to share their stories. And actually, I think that's a big part of it too. You've created a community through Shatterproof for people to share their stories and lean on each other and understand that they're not alone, that community alone. But of all of those things, what do you think Brian would be most?
It's a great question. I don't know how to answer it because there's so much I think that we're doing that started with him that he would be proud of. One of the things that we do that I really connect with, I know we're doing a lot behind the scenes, reducing stigma, what we've done in the treatment system, et cetera. But a lot of that is digital. When we bring people together in person at an event, and we do these 6 big walks around the country in 6 major cities. And it's on our website and events if anyone is interested. There is nothing more emotionally better for me to be at a walk with a couple thousand people. And it's that half hour before the walk where we have, 6 5-minute speeches of people coming at it from different perspectives. And then the walk afterward where people hug, they cry, they laugh. I remember a young man came up to me at our golf event. We have a golf event in Connecticut every year for Shatterproof. And he came up to me a couple of years ago and said, Gary, I'm 32 years old. You haven't met me yet. He introduced himself. I couldn't stop using drugs for 15 years. I just couldn't stop. One of my friends convinced me to go to your walk in New York City in 2018. It was the first time in my adult life that I felt accepted. There were 2,000 people around saying, we accept you. And he said, I never felt better. He said, 3 days later, I used my last substance. And in 2 weeks, it'll be 3 years where I haven't used a substance. It's stories like that. And I can give you 100 of them. One-on-one, a mother comes up to me and hugs me and shows a picture of her son and says, the law you passed in our state saved my son's life. Someone I'll meet at an event and said, what you told me last night when we met in the lobby of the hotel, I called my brother and told him how proud I am of him. It was the best conversation I had with my brother in the last 5 years. I disrespected him. But after hearing what you told me, I called him up and told him how proud I am of him. Those are the things that it's the two sides of it. It's the helping hundreds of thousands, if not millions of people on one side, but it's the individual stories that are just so powerful. And I would encourage anybody listening here, if you're in a city near one of our walks, there's nothing better to being with people can share their emotions and support those who've either lost a loved one or support a loved one who's recovering and doing well or struggling or any form of that.
Wow, that's very moving. And the fact that you have that many stories like that. As a practicing clinician, I get to hear stories like that, but not at the scale that you do. So I really admire what you're doing. I guess I have just one more question, which is how can people get involved? I mean, you mentioned the Shatterproof walks, you mentioned your website. Is there anything else that anyone who wants to get involved with the wonderful work you're doing at Shatterproof would need to know?
If anyone wants to even just learn how they can get involved in different ways, just go to our website. Across the top, it says get involved, and then it'll open up to that page, and there's a variety of ways. You can volunteer an event, you can attend an event, you can fundraise, you can be an ambassador. If you're an ambassador, it's a little bit more involved than a volunteer, and you get invited to monthly seminars to learn more about what we're doing. Whether you're a volunteer or ambassador, there's no requirements. There's a variety of things you can lean into. It could be coming to one of our events and helping us run it. It could be spreading the word in your local community. It could be taking a step further and let us train you to go to a public hearing to tell your story so we can try to get a law passed in your state. It could be you reaching out to a legislator that you know. It could be you're fundraising for us. You could create your own event. You can create a bake sale in your driveway for those with a substance use disorder and create your own event. You can create a golf event in your community. There's zillions of things, no requirement, any way that's comfortable for you. And we would instantly connect you with a woman that runs it. She has people that work with her and love to get people involved in any way comfortable.
Thank you so much for providing that information. Every time I hear about what you're doing, there's like more and more to the story. There's more and more to it. And these are such profound ways.
We just had an event 2 towns away last week on a Wednesday night. A father who cares about this cause. He donated the services of his restaurant for a night. We actually, the restaurant kept operating, but out on the balcony, we had an event with about 20 local people that he and a few others invited to learn about Shatterproof. And they can lean in if they want, no requirement. Some can donate. Some can ask their friends if they want to donate. Some will come to the walk. Some will spread the word to 5 others who may want to learn about Shatterproof, so the concentric circle keeps going.
This has such a parallel with the way that we help people who are trying to overcome a substance use disorder, as you're speaking, is that we kind of open up the gates and we say, hey, we're here to help you, whatever that means. And I know we didn't end up talking much about harm reduction, but we're here to meet you where you're at and help you reach your goals, wherever they are. And it's just interesting how you have that parallel with the way that you invite people to participate in Shatterproof in whatever way is meaningful to them. And ultimately, that's what drives and motivates people to want to be part of something. So I can see why you have such a following now at Shatterproof.
Well, thank you. And again, there's so many people helping us in so many different ways, in any way that's comfortable for them, that they want to lean in.
Well, I want to thank you so much for the time you spent with me today, but not just the time, but for being so authentic and open and for speaking from the heart while simultaneously holding all that you know. It's been a really enlightening conversation for me, and I hope it was for you as well. I know it will be for this audience. So thank you.
Wonderful. Thank you. Thank you for having me. And thank you for educating the public.
Thank you for tuning in. I look forward to seeing you next time.